I've cared for hundreds of dying patients. I've watched people take their last breath more times than I can count. But there was one night at a hospice that made me leave the job for good, and I still don't have a clean explanation for what happened. My name is Linda Carver. I'm a nurse. I was 45 years old when this happened, and I had already spent 17 years working in hospitals and hospice care. By that point in my career, very little surprised me. I'd seen patients hallucinate from pain medication, confuse nurses for relatives, argue with doctors who weren't even in the room, and say things that made no sense to anyone but themselves. If you work long enough in a hospital, especially in hospice, you learn not to react to strange statements. You chart it, you note it, and you move on. Hospice is different from a regular hospital unit. We're not there to fix people. We're there to keep them comfortable. We manage pain, anxiety, nausea, and fear, a lot of fear. Patients know why they're there, even if they don't always say it out loud. Families know too. Everything moves slower in hospice, especially at night. Fewer alarms, fewer staff, a lot more quiet. That night started like dozens of others. It was a weekday night shift at Silver Willow Hospice Center, just outside Boise. I'd worked nights for years because I liked the calm and the predictability. Night shift is when things either stay very quiet or go sideways fast. There's usually not much in between. I was assigned 4 patients, nothing unusual. One of them was Thomas Hale, a 62-year-old man with advanced pancreatic cancer. He'd been admitted a few days earlier for pain management. His chart was straightforward: no psychiatric history, no cognitive issues, no signs of delirium. He was alert, polite, and painfully aware of his prognosis. The kind of patient who apologizes for pressing the call button. Earlier that evening, his pain had spiked despite his scheduled meds. The hospice physician ordered a small increase in morphine and added lorazepam for anxiety. That combination is extremely common in end-of-life care. If you've ever worked hospice, you've given those medications more times than you can remember. When I went into his room to administer the meds, Thomas thanked me like I was doing him a personal favor. That's another thing hospice nurses get used to: gratitude for things that shouldn't require gratitude. I explained what I was giving him, checked his vitals, and pushed the meds slowly through his IV. He closed his eyes, took a few deep breaths, and relaxed into the mattress. At that point, everything was normal. About 20 minutes later, I was at the nurse's station charting when his call light came on. That alone wasn't unusual. What caught my attention was how quickly it came on after the medication. Most patients get drowsy and drift off. They don't usually ring for the nurse. I walked back into his room expecting to find him disoriented or uncomfortable. Instead, he was awake, not restless, not agitated, awake and focused. He looked straight at me and said my name. Not nurse, not hey, my name. That gave me pause. I hadn't introduced myself during that interaction, and I was covering a different hallway earlier in the shift. Still, patients overhear things. It happens. But then he said very clearly, "It's Tuesday night. You're at Silver Willow." And I'm not confused. That was the moment I felt something shift. Patients on morphine and lorazepam don't usually announce their orientation like they're reciting a neurological exam. His speech wasn't slurred. His eyes weren't glassy. His voice wasn't slow. If I'd walked into that room without context, I would have assumed he hadn't received anything stronger than Tylenol. I did what nurses do. I ran through the checklist in my head. Oxygen saturation was normal. Heart rate steady. No signs of respiratory depression, no agitation, no obvious delirium. Then Thomas said, "I need to tell you something because I don't think I'll get another chance." That was the exact sentence where I stopped thinking about charting and started paying attention. If this story already has you uncomfortable, go ahead and drop a comment. Nurses and doctors know this feeling the moment when a patient says something that doesn't fit the situation. And if you want to hear how this night spiraled, make sure you subscribe, because this is one of those real nurses' stories that stays with you long after the shift ends. I pulled a chair closer to the bed, partly because it was late and partly because his tone wasn't panicked. It was urgent but controlled. He wasn't scared. He was serious. Thomas told me that when the medication started working, he didn't fall asleep. He didn't drift. He didn't lose awareness. He said it felt like stepping into another place, somewhere quiet and bright. He didn't describe it in poetic terms. He didn't sound dramatic. He spoke the way people do when they're trying to be accurate. He said there were chairs arranged in rows, People sitting in them, not talking, not moving, just sitting. He said he knew somehow that they were dead, not dying, dead. I kept my face neutral. Nurses get very good at that. Then he said there was one person there who didn't belong. Someone younger, someone who looked scared, someone who kept repeating the same thought over and over like it was stuck. "They're not done with me yet," Thomas said, watching my face closely. That was when I realized this wasn't going to be a normal hospice night, and it wasn't going to be something I could chart away with a checkbox and a note. I stayed standing next to the bed for a moment longer than necessary, my hand still resting on the rail, because walking away too quickly would have felt wrong. Thomas watched me the way patients do when they're trying to read whether they've crossed some invisible line. I told him I was going to check his vitals again, not because anything looked off, but because it gave me something familiar to do with my hands. The monitor showed exactly what I expected: oxygen saturation in the mid-90s, heart rate steady, blood pressure a little low but appropriate for someone resting comfortably after pain medication. His breathing was slow and even. Nothing about his body suggested distress, panic, or confusion. If I'd been rounding on him without context, I would have documented resting comfortably and moved on. Hospice trains you to focus on what you can measure, because what you can't measure will drive you crazy if you let it. Pain scores, respiratory rate, skin color, level of alertness. We're taught to ground ourselves in those things when conversations drift into territory we can't fix. I asked Thomas if he was in pain. He said no. I asked if he felt anxious. He said no. I asked if he knew where he was. He answered without hesitation. Then he smiled, a small, tired smile, and said, "I know this sounds strange, but I'm not scared." That line landed heavier than I expected. Most hospice patients are scared, even when they say they aren't. Fear leaks out in other ways: clenched hands, shallow breathing, a voice that keeps circling the same questions. Thomas didn't have any of that. I adjusted his pillow and told him I'd be nearby if he needed anything. It was a professional exit, clean and calm. I didn't ask follow-up questions. I didn't challenge what he'd said. That's another thing hospice nurses learn early. You don't argue with someone's experience when they're at the end of their life. You acknowledge, you support, and you protect their comfort. Back at the nurse's station, I sat down and stared at the computer screen without typing anything. The chart was open, cursor blinking in the note section, waiting for me to reduce a very strange interaction into something acceptable for medical documentation. There isn't a checkbox for patient reports being in a place full of dead people. I wrote that he was alert, oriented, calm, and comfortable after medication administration. That was true. I left out everything else. That was also standard practice. Hospice nights have a rhythm. You do rounds, you give meds, you sit with families who don't want to be alone. You listen to breathing patterns change. Most of the time, the work is quiet and repetitive in a way that's almost meditative. That night, every small sound felt louder than usual. The hum of the refrigerator in the break room, the squeak of my shoes on the hallway floor, the soft buzz of call lights. I checked on my other patients. One was sleeping. One needed repositioning. One wanted ice chips. Normal things. I joked quietly with another nurse about the terrible coffee. She laughed. Nothing about the unit felt off. Nothing about the environment supported the feeling I couldn't quite shake. Around midnight, I passed Thomas's room again. The door was slightly open and the light was dimmed. He was awake, staring at the ceiling, breathing evenly. He didn't call out to me, he didn't wave, he just looked content, like someone waiting for a late flight. I kept walking. That's the part that bothers me now more than anything else. I didn't feel alarmed. I didn't feel the need to escalate. I felt something closer to curiosity, mixed with a kind of professional restraint. Hospice nurses hear unusual stories all the time. Some patients see relatives who've already passed. Some talk about places they're going. Most of us file that under normal end-of-life phenomena and keep doing our jobs. I reminded myself of that as I passed the medication room. I reminded myself that morphine and lorazepam are known to alter perception. I reminded myself that the brain does strange things when it's tired, sick, and flooded with chemicals. There were plenty of explanations that didn't require me to do anything differently. Later in the night, the hospice physician called to check in. I gave a routine update. Pain controlled. Anxiety improved. No acute issues. I didn't mention the conversation, not because I was hiding it, but because it didn't seem clinically relevant. Doctors hear these stories too, and most of the time they nod, document, and move on. By 2 in the morning, the unit settled into that deep quiet that only happens in medical buildings at night. The kind of quiet that feels heavy rather than peaceful. I sat back down at the nurse's station and pulled up continuing education modules I'd been meaning to finish. End-of-life communication, symptom management, burnout prevention. I clicked through slides without really absorbing them. Every so often, my mind drifted back to Thomas's voice. Not the words themselves, but the way he'd said them. Calm, certain, like he was describing a waiting room he'd visited many times before. I caught myself wondering what I would have thought if he'd said it differently, if he'd been crying, if he'd sounded confused, if he'd asked questions instead of making statements. Those versions would have been easier to categorize. Near the end of my shift, I went into his room one more time to check his comfort. He turned his head toward me and said, "I'm okay. Nothing else. No follow-up, no urgency, just a simple update." I nodded and told him to rest. When I handed off to the day nurse a few hours later, I gave a standard report. Diagnosis, meds, response, no red flags. Thomas's night sounded uneventful when summarized out loud. That's how most hospice nights sound in report, even when they aren't. Driving home that morning, I told myself I was overthinking it. Nurses do that sometimes, especially after long shifts. You carry conversations with you longer than you should. You replay tone and phrasing. You imagine meaning where there might be none. I went home, slept for a few hours, and woke up with that same unsettled feeling still sitting in my chest, quiet and persistent, like something unfinished that didn't need my attention yet, but refused to leave. I checked my phone before I even got out of bed, which is something I trained myself not to do on days off. There were no missed calls from the hospice, no urgent messages, no reason for the tight feeling in my stomach that showed up before my feet hit the floor. Still, Thomas's voice was already there, clear and uninvited, like it had been waiting for me to wake up. By the time I went back in for my next shift that evening, I'd talked myself into a more reasonable headspace. Patients say strange things. Hospice patients say even stranger things. If you let every unusual conversation follow you home, you won't last long in this line of work. I'd given that advice to new nurses more than once, and I repeated it to myself as I clocked in. Thomas was still assigned to me. That shouldn't have mattered, but it did. Seeing his name on the board triggered the same quiet unease I'd woken up with. I reminded myself that nothing medically significant had happened. No falls, no changes in status, no emergency calls overnight. If this were a real problem, it would have announced itself in a way I couldn't ignore. I went about my rounds like I always did, checked vitals, reviewed orders, greeted families, answered questions about pain control and timing. Everything stayed comfortably predictable until I stepped back into Thomas's room. He was awake again, propped slightly on his side, watching the door like he'd been expecting me. He smiled when he saw me, not relieved, not desperate, just aware. "You're back tonight," he said. I nodded. "Looks that way." He didn't ask how I was. He didn't ask for anything. He just shifted a little, adjusting the blanket over his legs, and said, "I was hoping I'd see you again." That was another subtle thing that didn't quite land right. Most patients don't keep track of individual nurses beyond who's on duty right now. They're focused on themselves, on their discomfort, on their families. Thomas seemed focused outward, like he was waiting for a continuation of a conversation we'd never officially started. I asked him how his pain was. He said it was manageable. I asked if he felt anxious. He shook his head. His vitals were stable. His breathing was even. His eyes were clear. Then he said, "I thought about what I told you last night." That was my cue to slow everything down internally. When patients revisit unusual statements, it can mean a lot of things. Sometimes it's anxiety, sometimes it's fixation, sometimes it's the beginning of confusion. I pulled the chair closer again, more deliberately this time, and sat down. "I don't expect you to believe me," he said. "I just don't want you to think I was confused." I didn't answer right away. Nurses learn that silence is often better than reassurance. People fill it with what they actually mean. Thomas told me that the place he'd been wasn't frightening. It wasn't peaceful either. It was neutral, quiet, like waiting at an airport late at night when all the shops are closed and the announcements stop. That comparison came from him, not me. And I remember it because it was oddly practical. He said the people sitting there weren't interacting with each other. They weren't aware of him the way living people are aware of someone entering a room. He said he knew without anyone telling him that they were finished, that whatever they had been, they weren't coming back. I asked him how he knew that. I just did. He said the question itself was unnecessary. Then he circled back to the one detail I hadn't been able to shake. The younger man, the one who didn't fit. He wasn't sitting the same way, Thomas said. Everyone else was still. He kept shifting, like he was uncomfortable, like he wanted to leave. I asked Thomas to describe him again, not because I needed the details, but because I wanted to see if they changed. Patients who are confabulating often alter their descriptions without realizing it. They didn't change. Young, mid to late 20s maybe, athletic build, scrapes on his hands. He mentioned a smell something like oil or metal, but he couldn't explain why that stood out. He said the man's fear was obvious, not dramatic, just raw. And he kept thinking the same thing Thomas said, not saying it out loud, thinking it. He looked directly at me when he repeated it. They're not done with me yet. I felt a very specific kind of discomfort then, the kind that doesn't spike your heart rate, but makes you acutely aware of your own posture, your breathing, the distance between you and the bed. I'd heard patients describe near-death experiences before. Light, tunnels, loved ones. This wasn't that. This was procedural, sparse, almost clinical. I checked myself mentally for signs of counter-transference. Another thing nurses are trained to do. Was I projecting? Was I filling in gaps? Was I letting my own curiosity turn into something inappropriate? I didn't feel emotionally attached to Thomas. I wasn't invested in his outcome beyond comfort. What bothered me wasn't how he felt. It was how precise he was. I told him I was glad he wasn't scared. That was true. Fear is harder to manage than pain. He nodded. I'm not. I just wanted someone to know. That was the first time it occurred to me that he wasn't telling me for comfort. He wasn't asking for reassurance. He was reporting something the way people do when they think information matters, even if they don't understand why. I documented the interaction more thoroughly that night, though I still used careful language. Alert, oriented, calm. Expressed unusual perceptions without distress. No agitation, no hallucinations observed. It was accurate if incomplete. As the shift went on, I found myself paying closer attention to him than I normally would. Not hovering, not obsessing, just noticing. His sleep patterns, his response times. Whether he repeated himself, whether his story drifted, it didn't. By early morning, Thomas was resting quietly. I stood in the doorway for a moment, watching his chest rise and fall, and felt something I hadn't expected. Not fear, not dread, a kind of professional irritation, like when a piece of equipment doesn't malfunction enough to justify replacing it, but just enough to make you uneasy every time you use it. At the nurse's station, I caught myself scrolling through the census list from the nearby hospital, something I did occasionally when coordinating transfers or consults. I wasn't looking for anything specific. I wasn't even sure why I'd opened it. I just knew in a way that didn't feel dramatic at the time that if I didn't ground this experience in something concrete, it was going to keep circling in my head long after Thomas stopped talking. I didn't click on anything at first. I just stared at the screen cursor, hovering over the census list, telling myself I was wasting time. Hospice nurses don't usually dig through hospital admissions unless there's a reason. At least that's what I told myself as my finger stayed on the mouse a second longer than it should have. The list refreshed automatically, names scrolling into place with diagnoses and timestamps. Motor vehicle accident, stroke, cardiac arrest, sepsis, the usual mix. I wasn't searching for a young man. I wasn't searching for anything specific at all. That's the lie I was most comfortable with in that moment. What caught my eye was the timing. One admission had come in just after midnight the night Thomas was first medicated. Male, 27 years old. Cardiac arrest following a single vehicle crash. Found unresponsive by a passing driver. CPR in the field. Return of spontaneous circulation before arrival. I told myself to close the window. This wasn't my patient. This wasn't my unit. This wasn't my role. But hospice nurses spend a lot of time coordinating with hospitals, especially when prognosis is uncertain. I had just enough professional justification to keep going without feeling like I was crossing a line. I opened the chart. The first thing I noticed was how ordinary it looked. No dramatic language, no unusual flags, Just labs, vitals, notes, written in the same clipped tone every ICU chart uses, the kind of chart you read dozens of times a week without thinking twice. If Thomas hadn't spoken, this would have meant nothing to me. I skimmed the timeline: arrival time, intubation, cooling protocol initiated, sedation, neurology consult pending. Everything followed protocol. Everything made sense. Then I saw the note from early morning. Patient briefly opened eyes, purposeful movement noted, appeared distressed, vocalized unintelligibly prior to sedation adjustment. I leaned back in my chair and exhaled slowly, not because the words confirmed anything, but because they narrowed the space between what Thomas had described and what was documented. ICU patients often wake up agitated. They often say things that don't make sense. There was nothing abnormal about that on its own. What bothered me was the overlap. The time the ICU nurse had entered that note was within minutes of when Thomas had been awake describing the other place with the same calm certainty. I checked the clock on my workstation, then checked the timestamp again just to make sure I wasn't misreading it. I wasn't. I closed the chart. That should have been the end of it. A coincidence. A tired brain making connections it didn't need to make. Nurses are pattern-seeking creatures. We notice trends, correlations, rhythms. That's part of staying alive in a hospital. Sometimes that instinct misfires. I stood up and walked down the hallway, moving without any real destination in mind. Thomas's door was closed now. The light was off. He was resting. I didn't go in. Instead, I leaned against the wall outside the medication room and tried to talk myself through the situation the way I would with a student nurse. What are the facts? One hospice patient described an experience after sedation. One ICU patient had an agitated awakening after cardiac arrest. Those things happen every day. The brain under stress is unpredictable, but the details wouldn't let go. Thomas hadn't described panic, he hadn't described chaos, he hadn't described confusion, he described order, structure, waiting, and the one person who didn't belong was the one who was still alive. I told myself that I was assigning meaning where there was none, that hospice work makes you overly sensitive to death-related narratives, that end-of-life care blurs emotional boundaries in ways other specialties don't. All of that was true. None of it was satisfying. Over the next few hours, I found myself checking Thomas's room more often than necessary, not because he needed anything, because I was watching for inconsistency, slurred speech, repetition, any sign that his story would unravel the way hallucinations often do. It didn't. When he was awake, he was oriented. When he slept naturally. When he spoke the way he always had. Calm, measured, not rehearsed, not vague. At one point, while I was adjusting his IV tubing, he said, "You're trying to figure out if I'm making this up. It wasn't accusatory. It was observational. I didn't deny it. I'm trying to understand," I said, which was also true. He nodded. I would too. That was it. No elaboration, no attempt to convince me. That lack of urgency bothered me more than anything else. People who are fabricating experiences usually want validation. Thomas didn't seem to care whether I accepted his explanation. He just wanted it registered. Later that night, during a lull at the nurse's station, another nurse asked me if I'd seen the new admission numbers from the regional trauma center. Apparently, it had been a rough week for motor vehicle accidents. I nodded and made a non-committal noise, hoping my face didn't give me away. The chart I'd closed earlier felt heavier now, like something I'd put down without actually setting aside. By the end of the shift, I had convinced myself I wouldn't look at it again. I'd crossed close enough to the line to recognize it. Professional boundaries exist for a reason. If you start chasing every strange overlap, you'll lose perspective fast. Driving home that morning, the sky still dark, I replayed Thomas's words again, not because I wanted to, but because my brain refused to let them go. They're not done with me yet. It didn't sound like something a dying man would invent. It sounded like something a living one would think. I slept poorly that day. Not because of nightmares or dramatic images, but because my mind kept toggling between two explanations that didn't touch each other. Either this was coincidence layered on coincidence, or there was a gap in my understanding that I didn't have language for. By the time I returned for my next shift, the discomfort had settled into something more focused. I wasn't scared. I wasn't panicking. I was alert in a way that felt unfamiliar, like I was paying attention to the wrong channel and couldn't switch it off. When I logged into the system that evening, the ICU chart was no longer at the front of my mind. What was there instead was a quiet decision I hadn't consciously made yet, but could feel forming, the kind that starts as curiosity and ends as something much harder to step away from. I poured myself a cup of bad coffee and stood at the counter longer than I needed to, letting the bitterness cut through the fog in my head. If this were anything serious, I told myself it would look serious. Real problems in hospice announced themselves clearly. Sudden agitation, rapid decline, family panic. None of that was happening here. I decided the most responsible thing to do was exactly what nurses are trained to do when something doesn't make sense. Normalize it, contextualize it, reduce it to known variables. Patients at the end of life often experience vivid internal imagery. Sedatives alter perception. Hypoxia can distort memory. Stress fills in gaps with narrative. There were entire continuing education modules built around those explanations, so I leaned into them. During rounds, I asked Thomas neutral questions, not about the place he'd described, but about his sleep, his appetite, whether he'd noticed any confusion or strange dreams. I was careful with my wording. Leading questions create unreliable answers, and I didn't want to influence anything. He answered calmly every time. He slept when he was tired. He ate what he could. He didn't feel confused. He didn't describe dreams. He didn't volunteer anything new unless I asked directly, and even then, he didn't elaborate beyond what he'd already said. That consistency should have reassured me. In some ways, it did. Consistent narratives are easier to manage than chaotic ones, but they're also harder to dismiss. I talked to the hospice physician during our routine check-in. I didn't mention the ICU chart or the timeline. I framed it as a general question. Had she noticed patients describing structured experiences during sedation, ones that didn't seem distressing or disorganized? She said yes occasionally, especially with patients who were cognitively intact and aware of their prognosis. End-of-life awareness can be very specific, she said. It doesn't always look the way people expect. That answer fit neatly into the explanation I wanted. I thanked her and moved on. Later, one of the social workers mentioned that Thomas's family had noticed how calm he'd been since admission. He wasn't withdrawn. He wasn't depressed. He was oddly settled, like someone who'd accepted something privately and didn't feel the need to announce it. Families often find that unsettling, she said. It makes them feel left behind. I nodded, filing that away. Acceptance, peace. Another box checked. Still, I found myself thinking about the ICU patient Ryan more than I wanted to admit. Not emotionally, analytically. Cardiac arrest survivors often report fragmented experiences, sensations without structure, fear without imagery. Thomas's description had structure. That difference mattered. During a quiet stretch in the middle of the night, I opened a medical journal article on near-death experiences. I didn't go searching for validation. I went looking for contradictions. Most of the literature emphasized variability, cultural influence, personal belief systems, religious framing. None of that lined up with what Thomas had said. His account was oddly stripped of symbolism. No light, no tunnel, no relatives welcoming him, just waiting. I closed the article and rubbed my eyes. I was overthinking this. Nurses don't get paid to solve metaphysical questions. We get paid to manage symptoms and document accurately. Everything else is noise. I forced myself to focus on routine tasks, medication counts, chart audits, supply restocking. The familiar muscle memory of nursing helped ground me. It always had. Around 3 in the morning, I passed Thomas's room again. He was asleep this time, mouth slightly open, breathing slow and even. He looked like any other patient resting comfortably. If I'd taken a photo of him in that moment, there would have been nothing remarkable about it. That image stayed with me, the disconnect between how ordinary he looked and how precise his words had been. Near the end of the shift, I caught myself reopening the hospital census. Not because I was looking for Ryan's chart again. I told myself I was checking admissions for potential hospice consults. That was technically true. Hospice works closely with acute care, especially when prognosis is uncertain. Ryan's name was still there. His status had changed. Neurology consult completed. Sedation reduced. Spontaneous breathing trials planned. The language was cautious, but there was a note of optimism I hadn't expected. I stared at the screen longer than I should have, then closed it with a decisive click. That was enough. Any further digging would cross a line I didn't want to explain to myself, let alone anyone else. When I handed off my patients that morning, I didn't mention anything unusual. Not Thomas's calm, not his descriptions, not my own unease. Shift reports are for actionable information, and this didn't qualify. Driving home, I talked myself through it again. Coincidences happen. Humans connect dots that aren't meant to be connected. Hospice nurses are especially vulnerable to that because death is always present in the background. You start to see patterns everywhere if you're not careful. I went to sleep telling myself I'd done the right thing by not pursuing it further. I woke up a few hours later with the same thought waiting for me, unchanged and stubborn. Not fear, not curiosity, a sense that I was deliberately ignoring something that didn't care whether I acknowledged it or not. By the time I returned to work that evening, I had settled into a fragile truce with my own thoughts. I would do my job. I would stay within my role. I would not go looking for answers that weren't mine to find. As I walked past the nurse's station and logged into the system, that truce felt intact but thin, like something held together by habit rather than conviction. And I knew from experience that habits only last until something pushes back hard enough. I didn't plan to do anything different that night. That's what I told myself as I tied my hair back and scanned the assignment board. Plans imply intention. What I felt was more like pressure, subtle but constant, the kind that builds when you keep setting something down without actually letting it go. Thomas was stable, comfortable, awake intermittently, no new orders, no family emergencies. On paper, my shift was going to be easy. Ryan's name showed up again when I logged in, not as a chart I was supposed to review, but as part of a palliative consult request flagged for follow-up. That alone was enough justification to look at least professionally. When young patients survive cardiac arrest with uncertain neurological outcomes, hospice teams sometimes get looped in early, even if it's just to assess options. It doesn't mean end-of-life care is inevitable. It means medicine hasn't made up its mind yet. I opened the consult summary and read it slowly. Ryan Morrow, 27, no significant past medical history. Found unresponsive in his vehicle after a single car collision. Estimated downtime unknown. CPR initiated by first responders. Return of spontaneous circulation achieved in the field. Intubated, sedated. Hypothermia protocol completed. Gradual improvement noted. There was nothing extraordinary in any of that, except for how young he was and how close the timing still sat to Thomas's first experience. I checked the timestamps, again more out of habit than expectation. ICU admission, initial sedation, neurological reassessment. The window was still there, narrow and uncomfortable. I didn't need it to be exact. Close was enough to keep it lodged in my head. The rational part of my brain kept pointing out how many ICU patients wake up frightened and confused. How many say strange things that don't make it into charts because they're not clinically useful. How many families hear fragments of stories that never line up with reality. That part of my brain had decades of evidence on its side. What it didn't have was a way to dismiss the specificity. I finished my rounds and found myself standing in the hallway outside Thomas's room again. He was awake, eyes half-lidded, staring at the wall across from his bed. I didn't announce myself when I stepped in. He noticed anyway. "You look tired," he said. "Occupational hazard," I replied. He smiled faintly. "You've been thinking." I didn't confirm or deny that either. Some patients pick up on things you don't realize you're projecting, or maybe I wasn't hiding it as well as I thought. "I don't want to bother you with this," he said before I could redirect the conversation, "but I don't think that man is here anymore." That stopped me. "What makes you say that?" I asked, keeping my voice even. "He was gone when I noticed the place again," Thomas said. "The others were still there." He wasn't. He didn't look relieved. He didn't look sad. He looked observant, like he was reporting a change in the weather. I felt a flicker of something that wasn't fear exactly. It was the discomfort of having your internal timeline disrupted. If Thomas was right, then whatever overlap I'd been trying to explain away had already shifted. I didn't ask him how he knew. I didn't ask him when he noticed. I thanked him for telling me and made sure he was comfortable, then stepped back into the hallway with my pulse slightly elevated. I stood there longer than I should have, staring at the carpet, grounding myself in the texture under my shoes. This was where professional boundaries mattered. This was where curiosity turned into risk. And still, when the opportunity presented itself, I took it. Later that night, I checked with the charge nurse at the hospital where Ryan had been admitted. Not directly about him, not explicitly. I framed it as a general question about consult follow-ups and whether any young cardiac arrest patients had shown significant improvement. It wasn't deceptive exactly, it was selective. She didn't mention names, she didn't need to. One of them woke up more than we expected, she said. Scared the hell out of everyone when he first came around. We thought he was going to self-extubate. I thanked her and ended the call, my chest feeling oddly tight. That was confirmation enough for me, even without details. Waking up frightened, agitated, that lined up with what Thomas had described. I knew then that I'd crossed from passive observation into something more active, not investigation exactly. I wasn't collecting data, I wasn't building a case, I was checking reality against a narrative I hadn't asked for and didn't want to believe. Back at the nurse's station, I stared at my reflection in the darkened computer screen. This was how people get in trouble, I told myself. Not because they're reckless, but because they think they're being careful while slowly expanding their definition of reasonable. I went back to Thomas's room one more time before dawn. He was resting, eyes closed, breathing steady. He didn't open them when I adjusted his blanket. I stood there for a moment watching him sleep and realized something that surprised me. I wasn't worried about him anymore, not in the way hospice nurses usually worry. His pain was controlled, his anxiety was minimal. Whatever was happening internally didn't seem to be causing him distress. What I was worried about was myself. Specifically, how much attention I was paying to something I couldn't intervene in. Nurses are fixers by training. When you take that instinct and aim it at something that doesn't have an intervention, it turns inward fast. As my shift wound down, I documented everything by the book. No speculation, no commentary, just facts. I handed off to the day nurse with the same neutral tone I always used. Thomas slept, pain controlled, no issues overnight. Driving home that morning, the sky just starting to lighten, I replayed the phone call in my head. The casual way the charge nurse had mentioned fear, the lack of surprise in her voice. ICU patients wake up scared all the time, but that didn't explain why the moment Thomas thought the man was gone lined up so neatly with the moment Ryan woke up enough to terrify an ICU team. I told myself I was still within reason, still grounded, still thinking like a nurse. What I didn't admit, not even then, was that I had stopped asking whether this was coincidence and started asking a different question entirely. One that felt far more dangerous to hold on to because it didn't come with a protocol or a clear place to stop. I didn't wake up planning to talk to Ryan. That distinction matters because planning implies choice, and what I felt was closer to inevitability. By the time I parked my car that afternoon, the idea was already there, fully formed, like something I'd agreed to without remembering when. Hospice consults sometimes involve follow-up conversations with patients who improve unexpectedly. It's not common, but it happens. When prognosis shifts, someone has to close the loop, clarify goals of care, make sure nothing was missed. That gave me enough professional cover to walk into the hospital without feeling like I was trespassing. Ryan was no longer in the ICU when I arrived. He'd been moved to a step-down unit overnight. That alone told me a lot. You don't downgrade a patient unless they've shown meaningful improvement. I found his room after checking with the unit clerk, who barely glanced up as she pointed me down the hall. Ryan was sitting up in bed when I walked in, still pale, still thin, but unmistakably awake. No ventilator, no restraints, just a young man with a hospital bracelet and a look on his face that suggested he was still catching up to his own body. I introduced myself as part of the palliative care team, which wasn't a lie. I explained that my role was to check in, answer questions, and see how he was feeling now that he was more alert. Patients rarely argue with that framing. Hospitals teach you to accept whatever support shows up. He nodded, throat dry, voice a little rough. They told me I scared everyone when I woke up. That's not unusual, I said. ICU can be disorienting. He laughed weakly. I don't remember screaming or anything. I just remember being terrified. I asked him what he remembered before that. He shook his head. The accident was gone. The ambulance was gone. Everything between getting in his car and waking up in the hospital was a blank. I waited a beat, then asked the question the way nurses are trained to ask sensitive things gently and without expectation. Some people have memories or sensations from when they were unconscious. Did you experience anything like that? Ryan stared at the blanket for a few seconds, fingers worrying the edge of it. That pause told me more than his eventual answer would have. People don't hesitate over things that mean nothing to them. Maybe, he said. I don't know. It didn't feel like a dream. I stayed quiet. He took a breath. It was more like being stuck somewhere. Not dark, just bright and empty. My pulse ticked up slow and steady. I kept my face neutral, empty how I asked. There were people, he said, but not like people. They weren't doing anything, just sitting there. That was when I felt the ground shift under my internal explanations. Not collapse, just tilt. I asked him to describe the space, careful not to supply words he hadn't used. He talked about light without a source, about rows without knowing why they were arranged that way, about a sense of waiting that didn't feel patient or impatient, just suspended. I couldn't move, he said. I tried. It didn't work. I nodded the way clinicians do when they're listening but not reacting. How did that make you feel? Panicked, he said immediately, because I knew something was wrong, and I kept thinking the same thing over and over. I didn't interrupt. They're not done with me yet, he said. He frowned as soon as the words were out of his mouth, like he was surprised to hear them spoken aloud. That sounds stupid now that I say it. It doesn't, I said before I could stop myself. He looked up at me sharply. You've heard this before. It wasn't a question. I corrected myself quickly. I've heard a lot of different things from patients. There's no right or wrong way for the brain to process trauma. That was true as far as it went. Ryan leaned back against the pillows, exhausted. There was someone there, he added, standing close, a woman. She wasn't stuck like me. She was watching me. The room felt smaller suddenly. I adjusted my stance, grounding myself physically so my reaction wouldn't show. Do you remember anything else about her? I asked. He shook his head, just that she looked worried, like she was trying to remember me. That was enough, more than enough. I thanked him for sharing and didn't push further. Leading questions at that point would have crossed into something I couldn't justify even to myself. I told him to rest, to let the doctors handle the recovery, to focus on getting his strength back. All the appropriate things. As I stepped into the hallway, my legs felt unsteady, not weak, just disconnected, like my brain was lagging a few seconds behind my body. I leaned against the wall and closed my eyes briefly, breathing slowly until the familiar environment reasserted itself. This was no longer coincidence layered on coincidence. This was convergence. Two people, two medical settings, two states of altered consciousness, the same core experience stripped of cultural or emotional decoration, the same phrase emerging independently like a shared file accessed from different locations. I replayed Ryan's words as I walked back toward the exit, not dramatizing them, not inflating them, just hearing them as he'd said them, uncertain and confused and a little embarrassed. That mattered. He wasn't trying to convince me of anything. He wasn't looking for meaning. He was reporting something he hadn't yet decided how to feel about. In the car, I sat with the engine off longer than usual. Nurses are trained to escalate when something poses a risk to patient safety. This didn't fit that category. No one was in danger. No intervention was needed. And yet I felt a growing sense that ignoring this would cost me something internal I couldn't quite name. By the time I drove home, the rational explanations I'd leaned on for days had thinned to the point of transparency. I could still see them. They were still technically valid. They just no longer held weight. I didn't tell anyone about the conversation, not the hospice physician, not my colleagues, not even the nurse I trusted most on night shift. Some experiences are isolating not because they're dramatic, but because they don't fit into existing language. That night when I lay down to sleep, my mind didn't race. It settled into a quiet, focused awareness, replaying the details with clinical detachment, light, stillness, waiting. The absence of fear in one patient, the raw panic in another, the same thought surfacing in both. I realized somewhere between wakefulness and sleep that whatever this was, it wasn't something happening to Thomas or Ryan alone. It was something I was now part of, whether I wanted to be or not. And that recognition carried a weight that made it impossible to approach the rest of my job the way I always had, even as everything on the surface continued to look exactly the same. I noticed the change in myself before anyone else did. It showed up in small practical ways, the kinds of things only another nurse would recognize. I double-checked medication doses I'd given thousands of times. I paused before entering rooms, not out of fear, but out of hesitation, like I was bracing for information instead of symptoms. Thomas was declining slowly the way pancreatic cancer patients often do when pain is managed well. His body was failing, but his mind stayed sharp. That combination is both a gift and a burden in hospice. Patients like that see everything clearly, including what's coming. When I went into his room that evening, he was awake, hands folded loosely over his abdomen, eyes following the movement of the IV pump like he was tracking time. "You look different," he said. I exhaled through my nose. "That's vague," he smiled, more careful. That was accurate enough that I didn't argue with it. I checked his comfort, adjusted his pillows, and went through the motions that had once felt automatic. The room smelled faintly of antiseptic and something warmer underneath the scent. Hospice rooms develop no matter how often they're cleaned. It was familiar. It should have been grounding. Someone else was there, Thomas said without preamble. My hand froze briefly on the IV tubing before I forced it to keep moving. "What do you mean a woman?" he said. "She wasn't sitting." I waited. "She didn't stay long," he added. "She wasn't supposed to." I turned to face him fully then. "Did you recognize her?" He shook his head. "No, but she recognized me." That should have been the moment I stopped the conversation, redirected, grounded him, documented potential fixation. That's what the training says. Instead, I asked the question I hadn't planned to ask. "What did she say?" "She didn't say anything," Thomas replied. "She just looked at me like she was surprised I could see her." The room felt warmer suddenly, or maybe I was more aware of my own body than usual. I checked his vitals again deliberately. Everything was stable. His oxygen saturation was unchanged, his heart rate steady. "This was after your medication?" I asked. "Yes," he said, "but not right away. It's not like before." That distinction mattered. He wasn't describing a single episode tied directly to sedation. He was describing intermittent access, the way you describe something that happens when you're not trying to make it happen. I finished my assessment and stepped back, my mind working faster than I wanted it to. A third person, a woman, not stuck, not waiting. "Is she alive?" I asked immediately, aware of how strange that sounded. "I think so," Thomas said. "She felt heavy, like she hadn't let go yet." I documented the interaction in neutral language, heart pounding in a way that had nothing to do with emergency, expressed unusual perceptions, no distress, no agitation, insight intact. That last phrase felt dishonest even as I typed it. Later that night, I received a message from the hospice social worker asking if I'd spoken with Thomas's sister recently. Evelyn Brooks had called earlier, concerned about a strange experience she'd had during a pain management procedure. That was when the pieces shifted into a new configuration. Evelyn wasn't a hospice patient. She wasn't terminally ill. She wasn't even particularly anxious, according to her chart. She'd undergone a routine interventional procedure at a pain clinic earlier that week with moderate sedation. The kind of sedation that relaxes you without knocking you out completely. I called her the next morning, framing it as follow-up support. That was within my role. Family members often need reassurance, especially when their loved ones are nearing the end. Evelyn's voice was steady when she answered, but there was an undercurrent of urgency, like she'd been waiting for someone to take her seriously. "I didn't want to scare anyone," she said, "but I know what I experienced." I let her talk without interruption. She described feeling disconnected during the procedure, aware, but not present. She didn't lose time, she lost context. She described a bright space without edges, people sitting quietly, and a sense of knowing she didn't belong there. Then she mentioned Thomas. "I saw him," she said. "He was sitting near the back. He looked tired but not sick. When I realized he could see me, he stood up." My grip tightened on the phone. "What did he say?" I asked. She didn't hesitate. "You don't belong here yet." The words landed with a dull finality that made my stomach drop. Not dramatic, not shocking, just heavy. Evelyn went on to explain that the experience ended abruptly, like being pulled back into her body without warning. She woke up in the procedure room disoriented but physically fine. The staff had reassured her it was a common reaction to sedation. "I know what sedation feels like," she said quietly. This wasn't that. I thanked her for telling me and ended the call as gently as I could. When I sat back in my chair, the room felt unnaturally quiet, like the air had been sucked out without changing the pressure. 3 people, 3 different medical contexts, 2 facilities, 1 hospice patient, 1 trauma survivor, 1 family member undergoing moderate sedation. There was no single explanation that covered all of it without stretching past what medicine was willing to claim. That realization didn't bring panic. It brought clarity, the kind that arrives when denial finally runs out of places to hide. Whatever was happening wasn't an isolated phenomenon tied to a specific drug diagnosis or environment. It was something that appeared when consciousness was loosened from its usual anchors. Back at the hospice that night, I moved through my shift with mechanical precision. I administered meds, I answered questions, I supported families. On the outside, nothing had changed. On the inside, I was recalibrating every assumption I'd ever held about what my job actually involved. Thomas was asleep when I checked on him. His breathing was shallow but regular. I watched him for a moment longer than necessary, then stepped out quietly. At the nurse's station, I stared at the task list on the screen, the familiar structure suddenly feeling inadequate. Nursing protocols are designed for bodies. They don't account for experiences that slip through the cracks between physiology and awareness. I didn't feel special. I didn't feel chosen. I felt burdened with information I couldn't act on in a system that values action above all else. By the end of that shift, I wasn't questioning whether the experiences were real to the people who'd had them. I was questioning whether my role as a hospice nurse required a level of emotional distance I could no longer maintain now that I'd seen how thin the boundary actually was. The thought followed me home, quiet but insistent, reshaping the way I looked at every interaction, every medication, every moment when a patient's eyes closed and their awareness went somewhere I could no longer pretend was simply nowhere. I hesitated before pushing the medication cart down the hallway, my hand resting on the handle longer than necessary, because for the first time in my career, the routine felt fragile. The cart hadn't changed. The meds hadn't changed. I had. That realization followed me into every room, quiet and relentless. Hospice work depends on trust. Patients trust you to manage their pain. Families trust you to guide them through something they've never had to navigate before. Nurses trust themselves to stay grounded while everyone else is falling apart. That balance only works when you believe deep down that what you're doing is contained, that it ends at the bedside. I no longer felt that containment. I started noticing how often patients drifted inward after medication, how frequently their eyes unfocused just before sleep. These were things I'd seen for years without attaching meaning to them. Now my brain tagged each moment automatically. Was this comfort or transition, relief or disconnection? I hated that I couldn't stop asking. My documentation became slower, more deliberate. I reread notes before signing them, worried I'd miss something obvious, something that would explain everything if I caught it in time. I didn't find anything new. That should have reassured me. Instead, it made the uncertainty feel more permanent. Colleagues noticed before I admitted it to myself. One nurse asked if I was getting enough rest. Another joked that I looked like I'd picked up extra shifts somewhere else. I smiled and deflected. Nurses are good at that too. We know how to perform competence even when it's starting to crack. The hospice physician pulled me aside during rounds one afternoon. She didn't accuse or confront. She asked a simple question. "Are you okay?" I gave the answer I'd given patients and coworkers for years. "I'm fine." She didn't push, but her eyes lingered, assessing. Doctors notice patterns the same way nurses do. A change in pace, a shift in tone, nothing dramatic, just enough to register. Thomas declined quickly after that. His appetite disappeared. His sleep stretched longer. The window for meaningful conversation narrowed. That at least followed a familiar trajectory. I focused on managing his comfort, grateful for something that still made sense. The night he became actively dying, the unit was quiet in that heavy way hospice gets when everyone seems to be holding their breath. His sister sat at the bedside, holding his hand, whispering things I didn't interrupt. I monitored from the doorway, adjusting medications as needed, doing what I'd done countless times before. Thomas opened his eyes once briefly and looked directly at me. There was no urgency in his expression, no fear, just recognition. "She's not here," he said softly. I nodded because nodding was easier than speaking. That was the last thing he said. After he passed, I completed the post-mortem care with practiced efficiency, cleaned his body, removed lines, documented the time of death, supported his sister. The mechanics of death are strangely grounding. They leave little room for interpretation. I thought that once Thomas was gone, the weight would lift, that the story would end with him. It didn't. In the days that followed, I found myself hesitating before administering medications, especially sedatives. Not enough to compromise care, not enough for anyone else to notice, just enough that I felt it internally, like a pause my body inserted without permission. I started waking up before my alarm, heart already racing, mind replaying conversations that hadn't happened in years. Not just with Thomas, with other patients, other nights, other moments I'd filed away without question. Sleep became shallow, food tasted bland. The dark humor that usually carried me through hospice work dried up, leaving interactions feeling forced. I laughed at the right moments, but the timing felt off, like I was half a beat behind myself. The breaking point wasn't dramatic. It never is. It was a routine medication pass with a patient who reminded me of Evelyn, same age, same voice. As I pushed the medication, slowly watching her relax, I felt a surge of anxiety so sharp it made my hands shake. That had never happened before. I excused myself, stepped into the supply room and closed the door. I leaned against the shelves and focused on breathing, counting silently until the panic receded enough to function. That scared me more than any story I'd heard. Nurses can work through grief. We can work through exhaustion. We can even work through doubt. What we can't work through safely is fear of our own actions. I spoke to my supervisor the next morning, not in detail, not with theories or explanations. I told her I was struggling, that the work was affecting me differently than it used to, that I didn't feel as steady as I needed to be. She listened without judgment. Burnout is common in hospice. Secondary trauma is practically an occupational hazard. She suggested a leave of absence, time to reset, time to regain perspective. I agreed, partly out of relief, partly out of shame. Nurses are supposed to be resilient. Admitting you're not feels like failure, even when it's framed as self-care. My last shift before leave felt surreal. The unit looked the same. The routines were unchanged. I said goodbye to coworkers without explaining why I was leaving. I told myself I'd be back, that this was temporary. At home, away from the constant presence of death, the questions didn't fade the way I expected them to. If anything, they sharpened. Without tasks to distract me, my mind circled the same unresolved points, searching for an explanation that wouldn't undermine everything I believed about my profession. I didn't want answers about the afterlife. I didn't want proof of anything beyond medicine. I wanted my work to feel safe again, predictable, contained. Instead, I was left with the uncomfortable awareness that hospice nursing requires a kind of emotional distance I could no longer maintain, not because I'd become weaker, but because something fundamental in how I understood consciousness had shifted. By the time my leave ended, the decision was already there, fully formed, waiting for me to acknowledge it. And every attempt to imagine stepping back into the hospice felt like forcing myself into a role I no longer fit, even though the badge and the training still said I belonged. I noticed the difference the first time I administered medication without a patient in front of me. The job I took after hospice was case management, mostly phone calls, care coordination, paperwork that lived entirely on a screen. No IVS, no sedatives, no watching someone's awareness slip away while their body stayed behind. On paper, it was safer, predictable, exactly what I told myself I needed. And in many ways it was. My days became quieter, my nights longer. I slept better, at least at first. Without the constant sensory input of hospice, my nervous system finally slowed down. No call lights, no labored breathing echoing down hallways, no families asking questions no one can truly answer. But the quiet had a way of making space for things I'd been avoiding. I found myself thinking about hospice patients in general, not Thomas specifically, about how often we assume unconsciousness is empty just because it's inaccessible to us. about how confidently medicine speaks about sedation as if turning awareness down is the same as turning it off. That confidence had always comforted me. Now it felt premature. When I reviewed charts from my new role, I noticed how casually phrases like patient resting and patient unresponsive were used. They're accurate clinically. They're also incomplete. Resting doesn't mean absent. Unresponsive doesn't mean gone. Those distinctions had never mattered to me before. They did now. I didn't become obsessed. I didn't start researching metaphysics or attending conferences on consciousness. I didn't change my worldview overnight. What changed was quieter than that, subtler, a shift in what I was willing to assume. Occasionally, I'd catch myself pausing during a phone call when a patient described feeling disconnected or strange after a procedure. Where I once would have redirected immediately, I now listened a little longer. Not to validate anything extraordinary, but to make room for the possibility that not everything important fits neatly into a chart note. I never told my new coworkers why I left hospice. I used the language everyone understands: burnout, emotional fatigue, wanting a change. All of that was true. It just wasn't the whole truth. Thomas's sister sent me a card a few weeks after his death. A simple thank you. No mention of experiences or conversations, just gratitude for care. I kept it on my desk longer than most cards, then eventually filed it away. Ryan recovered well. I know that because I checked once months later out of habit more than concern. He was back at work, physical therapy completed, follow-up appointments routine, no lingering cognitive deficits noted. His life had resumed its forward motion uninterrupted by whatever pause he'd experienced. That knowledge didn't bring closure. It didn't need to. It confirmed something simpler. Whatever had happened hadn't harmed him. It hadn't marked him. If anything, it had left him confused in a way most people eventually learn to live with. The experiences didn't haunt me in the way people imagine haunting. I didn't see things. I didn't hear voices. I didn't relive moments uncontrollably. What stayed with me was the awareness that my job for years had operated at the edge of something medicine doesn't fully understand, and I'd been comfortable pretending that edge wasn't there. Hospice is honest about death, but not always about what happens before it. We talk about comfort, dignity, symptom management. We don't talk much about awareness beyond the body, not because it's forbidden, but because there's nothing actionable we can do with that conversation. That doesn't make it meaningless. Sometimes late at night, I think about the way Thomas described waiting. Not fearfully, not hopefully, just waiting. That neutrality stands out more to me now than any dramatic detail ever could. Fear, I can manage. Hope, I can manage. Neutrality in the face of the unknown is harder to categorize. I don't believe hospice sends people anywhere. I don't believe nurses open doors or guide transitions. I don't believe there's a room full of chairs waiting for everyone. Belief requires certainty, and certainty is exactly what this experience stripped away. What I do believe is that consciousness is more fragile and more persistent than we like to admit. That loosening the brain's grip on the body doesn't necessarily erase awareness. It might just disconnect it from the signals we know how to measure. That idea used to terrify me. Now it just humbles me. I still trust medicine. I still trust protocols, evidence, and training. I still believe hospice care is one of the most compassionate services healthcare offers. Leaving it wasn't a rejection of that belief. It was an acknowledgement of my limits. Some nurses can sit comfortably at that boundary. I learned that I couldn't not anymore. When people ask if I miss hospice, I say yes, because I do. I miss the honesty of it. I miss the quiet moments. I miss knowing that my presence mattered in a very direct way. What I don't miss is the constant awareness that every medication I administered carried someone into a state I could no longer pretend was empty. This wasn't the worst case of my career because something went wrong medically. Everything went exactly the way it was supposed to. Pain was controlled. Anxiety was managed. No errors, no emergencies, no lawsuits, no investigations. It was the worst case because it left me with a question I couldn't unsee. And once you start questioning where awareness goes, when the body is quiet, it changes how you approach every patient, every procedure, every assurance that someone will simply go to sleep and wake up later. Most days, I don't think about it at all. I do my job. I live my life, I function just fine, and then once in a while I'll catch myself watching someone close their eyes during a routine procedure or listening to a patient describe a sensation they don't have words for, and I feel that familiar pause settle in gentle but firm, reminding me that not everything meaningful announces itself loudly. Some things just wait to be noticed, and once they are, they don't ask for belief. They just change the way you stand in the room, the way you listen, and the assumptions you no longer make so easily, even when everything around you insists that nothing unusual is happening at all. When I look back on that time now, I don't think the hardest part was what the patients experienced. It was what I was forced to accept as a nurse. Working in hospitals and hospice teaches you to rely on structure protocols and clear explanations. Doctors are trained to look for causes they can name. Nurses are trained to manage what we can see and measure. That system works most of the time and it saves lives every day. But every so often, you come across a case that doesn't fit neatly into the language of medicine. Not because it's supernatural, but because our understanding is incomplete. This wasn't a story about death being mysterious. It was a reminder that consciousness, awareness, and human experience don't always stop where our charts say they do. The lesson I took from this wasn't fear, it was humility. I learned that being a good nurse doesn't mean having answers for everything. Sometimes it means listening without forcing an explanation and knowing when a story changes you enough that you need to step away. These are the kinds of nurses' stories and hospital experiences that rarely make it into textbooks or training modules, but they quietly shape the people who work behind the scenes alongside doctors every day. If you've ever worked in healthcare, you know exactly what I mean. If stories like this resonate with you, if you're interested in real hospital experiences told honestly by nurses and doctors who live them, I invite you to subscribe to the channel. These stories aren't meant to shock or sensationalize. They're here to share what it's really like inside healthcare, in the moments when medicine does its best work, and in the moments when it quietly admits it doesn't have all the answers.